Good morning, good afternoon, and good evening, depending on your location. On behalf of ISCH, I welcome you all to ISCH Post-Congress webinar, Post-ASCO EHA webinar on highlights in ALL. This will be presented by our colleague and well-wisher, Dr. Lourdes Mendes. Dr. Mendes is a faculty and assistant professor of internal medicine, Division of Hematological Malignancy at Yale Cancer Center. She is hematologic oncologist specialized in the treatment of leukemia, particularly relevant to today's topic, acute lymphoblastic leukemia. Her research includes developing new therapeutic options for leukemia, and she has been participating in several global clinical trials in the field of hematological malignancy, especially leukemias. Dr. Mendes, the floor is yours.
Thank you for the kind introduction, Dr. Savani, and to the organizers for the invitation to speak on highlights in ALL at this year's ASCO and EHA. Oops. No disclosures to report. So today I am going to go over 6 abstracts from EHA and ASCO. The first 2 have to do with the treatment of younger adults, adolescents and young adults. The first abstract, the topic is the long-term results of the CALGB 10403 study. The second abstract is a subgroup analysis of younger adults from the E1910 study, which studied the combination of blinatumomab to chemotherapy in a randomized fashion. And then we'll switch gears to the topic of the treatment of relapsed refractory B-ALL, discuss a novel CD19 bispecific T-cell engager in this population, as well as further analysis of the FELIX trial and the response to obe-cel, ending with a novel regimen for the upfront treatment of Ph-positive B-ALL. So just as an introduction, acute lymphoblastic leukemia, as we all know, is a rare cancer. From the perspective of the United States, it represents 0.3% of all new cancer cases in the US, which in 2025 is estimated to amount to 6,100 new cases, roughly half and half pediatric and adult. Our patients often get a little bit enthusiastic when they compare the 5-year relative survival of ALL and AML, but in fact, this favorable outcome in relative survival is really still heavily carried by the pediatric population, where cure rates are over 80%, whereas outcomes in the adult population, there remains room for improvement as summarized by the median age at death, which is 60 years of age. So for our reference, I'd like to start with a look at historical outcomes, and again, this topic of the impact of age. What is summarized here is the experience with nearly 800 patients with B-ALL treated on one of several cooperative group trials in the US, but also abroad, as reported in 2017 by Dr. Roberts and colleagues in the JCO. We're looking at the overall survival. The 3 curves represent 3 different age groups. The blue curve is young adults aged 21 to 39 years of age. The yellow curve, those age 40 to 59, and the gray curve is so-called older adults, which in our field, acute lymphoblastic leukemia, starts somewhere between the age of 50 and 90. And these curves are associated in this historical experience with a 5-year overall survival of 45% in younger adults, 35% in the intermediate age adults, and a rather dismal 16% in the older adult age group. These less favorable outcomes with increasing age are mediated by increasing frequency of chemo resistance because of an increased frequency of high-risk genetic subtypes of B-ALL, as well as by decreased tolerance for the sort of multi-agent prolonged chemotherapy regimens that achieve excellent outcomes in pediatric age group, which has much much greater tolerance for this kind of therapy. So now turning to our abstract, starting with pH negative B-ALL. So the first abstract has to do with CALGB 10403. So to refresh together, CALGB 10403 started a bona fide pediatric regimen, which was in fact the standard arm of a children's oncology group protocol. So studied this bona fide pediatric regimen in the adolescents and young adults. And demonstrated, as published in Blood in 2019, that not only was it feasible to treat adolescents and young adults with such a regimen, but that the outcomes that were observed were improved compared to historical controls. So the survival at 3 years was 72%, and notably, there was no difference in outcomes between B and T ALL. So this was a large study, 295 eligible patients enrolled between 2007 and 2012. The median age was 25 years of age. So at EHA this year, Dr. Stock presented on behalf of investigators the update on on outcomes following 10 years of this trial. So at 10 years, the overall survival rate was 56%, and the event-free survival rate was 44%, meaning that after 3 years, events continued to occur. Notably, 25% of relapses for the patients with B-ALL, which represented just over 75% of the patients on this trial, occurred late, meaning after 3 years. And in fact, 6% occurred very late, after 5 years. By comparison, no relapses in the patients with T-ALL were observed after 3 years. So in the initial publication in 2019, the investigators had reported that favorable outcomes were observed in patients who attained an MRD negative remission after induction, whereas less favorable outcomes were observed in patients with the PH-like genotype, as well as patients with obesity as defined by a BMI of greater than 30, or the very obese subgroup with a BMI of greater than 40, which displayed inferior, not just disease-free survival, but also overall survival. So here in the update at 10 years, the excellent outcomes in the group of patients that achieved an MRD negative remission, which was defined with a sensitivity of 1 in 10,000 residual leukemia cells. So the excellent outcomes you can see in this graph persisted. So the disease-free survival for the MRD negative group at 10 years was 83%. And importantly, no events were observed after 3 years for this MRD negative group, indicating that achieving an MRD negative remission was protective against late relapses. So now turning to more contemporary regimens with the inclusion of blinatumomab, which is a CD19 bispecific T-cell engager, which directs T-cells to lyse CD19 positive B lymphoblasts. Its activity was demonstrated first in the relapse refractory setting in the pivotal Tower study. It was then shown to be a very powerful MRD eraser in patients who had 0.1% or more of residual leukemia in the BLAST study. And contemporary to the BLAST study arose the question of whether patients with even less amount of measurable residual disease could benefit from the addition of blinatumomab to chemotherapy. Since then, many studies have investigated the frontline incorporation of blinatumomab into a variety of regimens. For the most part, blinatumomab has been incorporated into consolidation because it's been shown that its optimal activity is really at a low disease burden setting. And so this is a selection of some of the frontline blinatumomab trials. Here we have from MD Anderson, sequential hyper-CVAD followed by blinatumomab 4 cycles as a part of consolidation. There's the GRAL 2014 sub-study that incorporated blinatumomab consolidation for the treatment of patients with high-risk disease, as well as the HOVON and LAL 2317. The HOVON is a study that incorporated blinatumomab into a pre-phase, not just consolidation. And there are additional studies that have studied blinatumomab as part of induction and not just consolidation, like the SWOG 1318 study and the ongoing Golden Gate study, which is investigating blinatumomab as a part of induction on all phases of treatment. So with upfront blinatumomab, the MD Anderson group reported a 3-year relapse-free survival of 74%. The GRAL sub-study reported a 2.5-year disease-free survival of 72%. And the HOVON and LAL 2317 also provided outcomes by age. At 4 years and 3 years overall survival for patients who were less than or equal to 60 years of age, or less than or equal to 55 years of age, ranged from 70% to high 80%, with that challenging older age population displaying 50% overall survival at 3 and 4 years. These were single arm studies where these outcomes were compared to the respective historical experience and in general compared very favorably. And the ECOG Akron E1910 study sought to study the question of whether blinatumomab improved outcomes in addition to chemotherapy in a randomized fashion. So this study accrued patients aged 30 to 70 years of age, and our next abstract is a subgroup analysis of this study. So it's a E1910, the backbone is a pediatric-inspired regimen. Patients are treated with 3 cycles of chemotherapy and then randomized either to continue with just chemotherapy consolidation or to the investigational arm with blinatumomab intercalated with chemotherapy. So between 2013 and 2019, 488 patients were enrolled. This was an international study. 286 of the 488 patients were randomized. Once blinatumomab was approved for MRD positive BALL, patients were no longer randomized if they were MRD positive, and only the MRD negative patients were randomized. Pre-specified stratification factors included age less than 55 or greater than or equal to 55. So as we know, E1910 met the primary endpoint of improved overall survival in the blinatumomab and chemotherapy arm, not reached as compared to 71.4 months in the chemotherapy arm alone. Again, this is not in the whole population that was enrolled, but in the MRD negative population, the question that E1910 sought to answer was whether blinatumomab further improved outcomes in these MRD negative patients. Only 58.6% of patients reached the randomization stage. At ASH, my colleague from Yale, Dr. Podoltsev, reported on the subgroup analysis of this challenging to treat patient population that is greater than 55 years of age. And you can see that from the overlapping and intersecting curves that there was no statistically significant difference in the 2 arms in this age group. Notably, the study was not powered to detect a difference in the 2 arms in this age group. And there are differences in how patients less than and greater than 55 years of age were treated. The older patients received less dexamethasone, less asparaginase at a lower dose, and only 50% of them received 4 cycles of blinatumomab. So at EHA, the investigators reported on the outcomes in the younger adult patients aged 30 to 54 years of age. Their disposition is shown here. 86% of younger adult patients achieved remission, not very different from the older patients, in fact. 2% of patients succumbed to toxicity during induction, so low rate of treatment-related mortality. However, amongst these 86% of patients who achieved remission, 29% did not reach the randomization stage due to death, recurrent disease, adverse events, or study withdrawal. And thus only 61% proceeded to randomization. Shown here is the overall survival of these younger adult patients who attained an MRD negative remission by treatment arm. So the 3-year overall survival in the blinatumomab arm was 92%, with a 3-year relapse-free survival of 86%, which was superior to the chemotherapy arm for both overall survival and relapse-free survival. So these are really excellent outcomes with rates that have historically only been seen in the pediatric ALL group. So in the prior abstract, we were looking at patients in the adolescent and young adult group. So E1910 included a subset of AYA patients aged 30 to 39 years of age. And what's shown here is for these AYA patients, overall survival and relapse-free survival. The 3-year overall survival was 100%, and the 3-year relapse-free survival was 90%. So again, outstanding outcomes. We could ask ourselves, does this perhaps reflect really low levels or low frequency of adverse genetics? At the beginning of the presentation, I mentioned that adverse genetic subtypes of Ph negative B-ALL are observed with increasing frequency with age. However, 29% of patients in the blinatumomab arm had an unfavorable molecular risk disease versus 15% in the chemotherapy arm. So these excellent results cannot be explained by the lack of unfavorable molecular risk disease. It is true that compared to enrollment and the time of stratification, there was a drop-off in the frequency of unfavorable risk disease. So drilling down into one subtype of unfavorable genetics, the Ph-like genotype. So shown here are the outcomes for the 19 patients with Ph-like B-ALL amongst the younger adult patients. The 3-year overall survival was 100%. The 3-year relapse-free survival was 100%. And these outcomes were achieved with a transplant rate of 37%. So to summarize the first 2 abstracts, the 10-year update from CALGB 10403 underscores that late relapses are observed occurring after 3 years at a substantial rate, 25%, and underscores not only this rate, but also the importance of long-term follow-up of clinical trials and as part of standard of care. By comparison, in T-ALL, no late relapses were observed with this treatment regimen after 3 years. End of induction MRD negative response was observed to be protective against late relapse in this 10-year update from C10403, whereas Ph-like disease and high BMI remained adverse factors in this update. In the second abstract, the younger adult patients aged 30 to 54 who were treated on the blinatumomab and chemotherapy arm experienced a superior outcomes in terms of survival, overall survival and relapse-free survival with the addition of blinatumomab to chemotherapy. And I didn't show you, but I think it's worth noting that interestingly, outcomes did not vary with the combination of blinatumomab and chemotherapy with obesity, as had been previously observed with C10403. So the excellent outcomes that were observed and that I showed you raise the possibility that in a subgroup of younger patients who attain an excellent early response, these intensive pediatric inspired regimens may be able to be de-escalated. And perhaps that will help to mitigate the attrition rate that was seen in terms of the patients who made it to receive blinatumomab, but additional strategies may also be needed to mitigate that attrition rate. Okay, turning now to updates in CD19 targeting immunotherapy beyond C10403 and E1910. So in the past year, the initial experience with subcutaneous administration of blinatumomab was reported and published by Dr. Aldos and colleagues, and this was also the subject of an abstract at EHA. In addition, novel CD19 bispecific T-cell engager was the subject of an abstract that we're going to go into in more detail, reported preliminary data for acceptable safety as well as preliminary efficacy. So in addition to the bispecific T-cell engagers, we're also going to touch on two abstracts that reported on obe-cel subgroup analysis and predictive variables as isolated from further analysis of the FELIX trial that led to the approval of obe-cel in the past year for relapsed refractory B-ALL. So starting with the novel bispecific T-cell engager AZD0486, as presented by Dr. Aldos on behalf of investigators. So this novel agent is a CD19, CD3 bispecific T-cell engager. It has as a special feature a low affinity CD3 binding property that reduces cytokine release from T-cell activation with the goal of making it safer, more tolerable, while preserving T-cell cytotoxicity against the leukemia cells. The activity of this agent was reported at ASH this past year in relapsed refractory non-Hodgkin's lymphoma. And at EHA this year, Dr. Aldos presented the preliminary results from the dose escalation portion of the CIRUS study. So the study design is shown here. It has three parts. Part A, phase 1A, is the dose escalation portion shown here, 3 dose levels. And the treatment strategy that was employed used a triple step up dosing treatment plan with the IV investigational agent infused on day 1, day 4, and day 8 in increasing doses in the first cycle, with the target dose administered on day 15, and then in subsequent cycles, cycle 2 and beyond, administration occurring on day 1 and day 15. So with this step up treatment strategy, and perhaps with the novel features of this CD19 bispecific T-cell engager, low rates of grade 2 and more CRS and ICANS were observed at approximately 9%. In terms of treatment emergent adverse effects that were observed, concomitant or commensurate with the study population, which is relapsed and refractory, there was about 30% grade 3 or more frequency of infections. There was slightly lower rates of neutropenic fever, and there were about 20% or so rates of grade 3 or more cytopenias observed. So shown here is the dose-dependent efficacy and the intention to treat population. So dose level 1, dose level 2, dose level 3. And here we see the dose-dependent trend in the overall response rate, ranging from 46% at dose level 1 to 83% at dose level 3. And importantly, this portion of the table is showing us and calling our attention to a particularly difficult to treat population of patients, which are those that have previously been exposed to CD19 targeting therapies. So those who have been exposed to CAR T cells, blinatumomab, and even those who have been exposed to so-called triple therapy in dose level 3 with very high rates of response, 80% to 100%. And I neglected to mention, but reassuringly, the high dose-dependent responses were associated with decreased risks of relapse. So in short, a novel agent that appears to be tolerable with promising preliminary efficacy. So turning now to the last two abstracts on CD19 immunotherapy, specifically on the CD19 CAR T cell therapy, obe-cel. So one slide to remind us regarding the FELIX trial. The FELIX trial had many cohorts, but the primary endpoint focused on the composite remission rate, so the overall remission of patients with morphologic disease at the time of enrollment. So cohort A, which I have signaled here. So the composite remission rate was 77% in this cohort, 52% CR rate, 20% CR with incomplete count recovery, well above the null of 40%. And so the study met its primary endpoint and led to the approval of obe-cel for relapsed refractory B-ALL within the past year. Shown on the right is overall survival with a very similar looking curve for event-free survival according to bone marrow burden before lymphodepletion, with the best outcome seen in patients with lower levels of disease. The top line, less than 5% blasts, the second line, 5 to 75% blasts, and then the third line, patients with a high burden of disease of greater than 75%. Importantly, a feature that makes obe-cel attractive is the low rates of grade 3 or more CRS and ICANS, 2% and 7% respectively, which were observed. So at EHA, Dr. Park reported on behalf of investigators the results of a multivariate analysis of predictors of sustained remission in patients treated on the FELIX trial. So among the variables that were most highly associated with the probability of achieving remission were, as you might imagine, based on the last slide, a low burden of disease versus a high burden of disease. And interestingly, also the pH positive genotype, which was associated with a 6-fold increased probability of achieving remission. And again, I think expected the number of previous lines of therapy, so less than or equal to 3 lines of therapy, as opposed to patients who are more heavily pretreated with more than 3 lines of therapy. The low versus high burden of blasts in the bone marrow was also associated with an improved event-free survival and overall survival, as was the persistence of CAR T cells, as one might imagine, for event-free survival and overall survival, and a previous allogeneic stem cell transplant for event-free survival. In addition, at the current period of follow-up of 3 or more years, 40% of responders remain in an ongoing remission without subsequent treatment, raising the possibility that this could be definitive consolidation for a subset of patients with relapsed refractory B-ALL. So also a further analysis of the FELIX trial, Dr. Shah at EHA presented the outcomes in patients infused with obe-cel by age. Again, with an interest in comparing the older age B-ALL patients who are more difficult to treat, who have historically experienced inferior outcomes, to those who are less than 55 years of age. This is a survival curve, and you can see that the lines are basically superimposed on one another, with an associated median overall survival of 15.5 versus 16.8 months. It is interesting, I think, to consider that the 2 age groups varied by more than just chronologic age, with less pH positive B-ALL, as one would expect in the younger patients, but more extramedullary disease, more prior exposure to novel agents, more patients of Hispanic ethnicity, and a much greater fraction of younger patients went on to transplant amongst those less than 55, whereas approximately 2% of the older patients went on to transplant. So just a word on targeted therapy. In the past year, the menin inhibitor revumenib was approved for the treatment of relapsed refractory KMT2A rearranged leukemias. And at EHA, there was a further update from the Augment 101 trial on acute leukemias that are non-KMT2A rearranged, but have a HOX gene upregulation that would be expected to also be disrupted by menin inhibitors. And responses were observed in non-KMT2A rearranged leukemia, specifically NUP98 rearranged acute leukemias. So together, paving the way for investigation in the upfront setting and KMT2A rearranged leukemias, but also those with upregulated HOX gene expression. So the summary of the last 3 abstracts that we have been discussing: the initial experience with the novel CD19 bispecific T-cell engager AZD0846 in relapsed refractory B-ALL suggests that it is well tolerated and active, importantly, including in patients with a prior exposure to CD19 targeting therapy, some with prior exposure to both blinatumomab and CAR T cells. In terms of the 2 abstracts that we talked about with updates from the FELIX trial, at 3+ years of follow-up from this trial, 40% of patients with relapsed refractory B-ALL remain in ongoing remission, as I noted, suggesting that for a subset of such patients, obe-cel may represent definitive consolidation. In addition, the activity in the difficult older age B-ALL group was found to be comparable to younger adults in the FELIX trial. And finally, the menin inhibitor revumenib induces responses in relapsed refractory HOX upregulated leukemias, in addition to KMT2A rearranged leukemias, which is promising in terms of opening up a therapeutic strategy for a whole other cadre of acute leukemias with menin inhibitors in relapsed refractory setting. And we will see in what outcomes are observed in the upfront setting. So finally, the last abstract is on the topic of the upfront treatment of Ph-positive B-ALL. So before we talk about this novel regimen, briefly, Ph-positive B-ALL occurs with increasing frequency with advancing age. It is, in the absence of a tyrosine kinase inhibitor, a chemo-resistant, and thus historically was a adverse risk subtype of B-ALL. The combination of chemo resistance and a population that is enriched for older adults made chemotherapy-free treatment and induction and consolidation attractive early on. The first efforts included the combination of tyrosine kinase inhibitors plus steroids, and the combination of dasatinib and prednisone was shown to result in high rates of hematologic remission and also molecular responses. However, relapses were not uncommon with mutations in the kinase domain, particularly with T315I mutations. In an effort to prevent relapses, contemporary trials and regimens have investigated the 3rd-generation tyrosine kinase inhibitor, ponatinib, which has activity against all kinase domain mutations, including T315I. And an alternative strategy to prevent relapses is to combine the allosteric inhibitor asciminib to dasatinib and prednisone during induction and consolidation. And the initial experience from a phase 1 multicenter trial was published by Dr. Luskin and colleagues in Blood this past year, reporting a favorable toxicity profile that allowed full dose administration of both dasatinib and asciminib. with promising evidence of activity, including progressive molecular responses that warranted further investigation. So another word before we talk about the abstract that was presented at ASCO on chemotherapy-free induction and consolidation strategies in pH-positive B-ALL. To remind us all, the D-ALBA study incorporated blinatumomab into consolidation following induction with dasatinib and prednisone, plus minus hematopoietic stem cell transplantation, which occurred in over 30% of patients who attained CR1. And with this treatment regimen were observed outstanding outcomes with event-free survival, disease-free survival, and overall survival at 4+ years, upwards of 70%. Shown here is the 4-year disease-free survival of 75.8%. And thus, building on the initial experience of dasatinib, asciminib, dual tyrosine kinase inhibitor regimen for the treatment of pH-positive B-ALL, the investigators went on to study an expansion cohort incorporating blinatumomab into consolidation. So induction consisted of asciminib and dasatinib, as well as prednisone administered for 28 days with a rapid taper of prednisone. And immediately afterwards, blinatumomab was added to consolidation for up to 5 cycles in patients 18 years of age and older with newly diagnosed pH-positive ALL. Hematopoietic stem cell transplantation was pursued at the discretion of treating physicians. At a median follow-up of 1 year at ASCO this year, Dr. Luskin presented the results and reported that there have been no relapses, and thus far, 5 of 15 patients have been transplanted. And thus, clearly, the addition of asciminib to dasatinib, this dual TKI strategy, together with blinatumomab, deserves further investigation. And asciminib in the treatment of pH-positive ALL is a very attractive approach, particularly in patients with a significant history of cardiovascular disease. With that, I'd like to thank you for your attention and open things up for discussion.
Thank you, Dr. Mendez, for your excellent present. One of my most favorite presentation, actually.
Oh, thank you.
Yeah, this was a great ALL presentation. As expected, we have received a number of great comments, positive comments, and some questions. So let me start with a few questions here. I have summarized some of those questions. So, we have now 2 CAR-T product approved for adult acute lymphoblastic leukemia for relapsed disease, obe-cel and Brexu-cel. How do you select? Let's say if we have both products available in our program as a standard of care, both are FDA approved, as you mentioned. How do you select? Which one you select? Obe-cel, Brexu-cel, any preference over other?
I think this is a hard question. And I think one of the things that could guide us is the low rates of CRS and neurotoxicity that were observed with obe-cel. And particularly if one is treating an older adult patient, I think this could be an important consideration and make obe-cel more attractive. There could be logistics depending on where one practices in terms of one versus the other. For those of us who practice in the US, obe-cel comes from abroad. But I would say in general, this is a difficult question to answer since all we can do is make indirect comparisons.
Good. So next, in a similar line, the question is, several people ask same question. What is your bridging regimen for ALL? Those patients need CAR-T therapy.
So My bridging regimen, I think, is not particularly surprising. It depends on what the patient has seen before. So if the patient has already seen blinatumomab and is CD22 positive and doesn't have a significant history of liver disease, then I will turn to inotuzumab. But if the patient is refractory to chemotherapy and has not yet seen blinatumomab, I usually use blinatumomab, just, very simply based on the data that shows both of these agents are superior to chemotherapy in patients who are refractory or relapsed.
So more or less similar lines of question.
I guess an additional answer could be, some of these patients might be on a clinical trial for relapsed refractory disease on their way to a CAR T cell.
So those patients who relapse after first-line therapy and then achieve second CR or close to how do you select patient for CAR T versus allo transplantation? When do you use when do you refer patient for allo transplantation nowadays?
This is one of the most difficult questions, I think, in our field. And the data on this is still accumulating, specifically in the setting of novel agents with blinatumomab and inotuzumab. I think one simple answer is who we don't refer. And I would say just like we have data from MRD negative end of induction remissions. Initially, the data was on MRD negativity per flow and showed that those patients had an excellent outcome. And then it's become deeper and deeper. And most recently by NGS at a sensitivity of 1 in a million, we see that even those patients who have high risk genetic subtypes, if they achieve this early deep remission, there is, to my knowledge, not yet published data, but presented data that they do not benefit from transplant. So I would say part of the answer is it would be reasonable not to transplant those patients. On the other hand, patients who achieve remission but have slower kinetics, like more persistent MRD, that certainly those that where it persists, whether they be low risk or high risk genetics, who are younger and fit, should still be triaged to transplant, particularly with genotypes such as KMT2A rearranged disease, hypodiploid, low or near haploid disease, and with PH-like disease, as we can see, there's data, I think, that is emphasizing that PH-like is a heterogeneous disease with some patients who can have really durable remissions, excellent outcomes in the absence of transplant. So that's a part of an answer. And I think that the answer was just for transplant, right? Or was it also how to triage to transplant versus CAR T cell?
Yeah, triage versus CAR T versus transplantation.
So choosing between transplant and CAR T is also difficult. If there's, the simple answer of if one happens to have a trial where CAR T is being investigated for first consolidation, that is a great answer to that dilemma. But otherwise, another way of making that decision is triaging patients to CAR T cells who are not, where there's concerns about their fitness to transplant.
This is very instigating question. Do you ever consider consolidation allotransplant in patient with CR MRD negative after CAR T therapy?
CR MRD negative after CAR T therapy. If it's an NGS early MRD negativity, personally, I would try to avoid transplant. and
Got it.
monitor prospectively. And, if there's any reappearance of MRD, then pursue transplant.
And this is last question on first-line therapy. A nice ASCO presentation, asciminib, dasatinib, blina plus steroid first line. And, there was a nice presentation or publication in JAMA last year, Falcon study, ponatinib plus chemo versus imatinib with chemo, and FDA approved that regimen. What is your first line therapy for Ph positive ALL nowadays?
That is a great question. I prefer TKI plus blinatumomab in patients who do not have a significant cardiac history, and it's always a question of how do you define that. I prefer ponatinib and blinatumomab. In patients who do have a significant cardiac history, dasatinib and blinatumomab.
Perfect. No, thank you. Thank you so much. We are over 1 minute now, but thank you, Dr. Mendez, for disseminating knowledge to help our patient. And I wanted to thank you all, our live audience, for joining the webinar. And for those not able to join, full recording of webinar will be available on ISCH website. Top class ALL presentation today. And this is in line with our mission of hematology without borders. Anyone can view all past recording anywhere in the world and anytime. Thank you all again, especially Dr. Mendez. Thank you for joining to short notice. Thank you.
Thank you, Dr. Savani.